All right, again, paper 9 has been moved to another session, or paper 8, so we're on to 9. So post-thrombotic syndrome, morbidity, and mechanical thrombectomy versus catheter-directed thrombolysis of iliofemoral DVT by Dr. Donna Hugh and colleagues from the University of Pittsburgh.
Good evening, everyone. I'm Jack Donahue, a second-year medical student at the University of Pittsburgh. Thanks to the Society for allowing us to present our work here tonight. We have no disclosures. So post-thrombotic syndrome is characterized as signs and symptoms of chronic venous insufficiency that develops following deep venous thrombosis. It's estimated that approximately 20 to 50% of patients with acute symptomatic iliofemoral DVT go on to develop PTS. The pathophysiology has been hypothesized to be due to valve damage and the resultant reflux, in addition to vein wall remodeling and a loss of vessel compliance. Villalta score is used to measure the signs and symptoms to diagnose PTS. Greater than 4 defines PTS, and greater than 9 defines moderate/severe PTS. So the goal of DVT treatment is really not only to alleviate the acute symptoms, but also to reduce the rates of post-thrombotic syndrome. The invasive treatment options for iliofemoral DVT include catheter-directed thrombolysis, pharmacomechanical thrombectomy, and more recently, mechanical thrombectomy. There's randomized data from the ATTRACT trial that demonstrates that pharmacomechanical thrombectomy for iliofemoral DVT significantly reduced early leg symptoms, PTS severity scores, and resulted in greater improvement in venous disease-specific quality of life measures relative to anticoagulation alone. So there's been a rapid proliferation of mechanical thrombectomy devices, but there's minimal data in the literature in support of these devices. The largest post-market registry data from the Inari Clot Retriever, and it's particularly encouraging. They've demonstrated high rates of thrombus removal and shown that 23.3% of patients develop PTS at 6 months, but the follow-up is far too limited. In general, there's minimal comparative or non-industry sponsored data. So we sought out to identify the risk of post-thrombotic syndrome in patients undergoing mechanical thrombectomy relative to the lysis-based therapies. We also sought to identify risk factors for post-thrombotic syndrome in patients with acute iliofemoral DVT. We had a cohort of 222 patients. This included patients with acute iliofemoral DVT treated with CDT, PMT, or MT from 2007 to 2021 at a multi-hospital healthcare system. We retrospectively collected demographics, comorbidities, DVT location, pre- and post-operative medication use, intraoperative characteristics, vessel patency, valve function, mortality, and Villalta score. We used multivariable logistic regression to assess for predictors of post-thrombotic syndrome, and we used multivariable linear regression to characterize Villalta score. Our primary outcome was post-thrombotic syndrome, defined as Villalta score greater than 4 at 2 years. Secondary outcomes included moderate/severe PTS, defined as Villalta score greater than 9 at 2 years, vessel patency at 1 year, mortality at 1 year, and valve function at 1 year. Upon investigating baseline characteristics, we noted that the groups were largely similar, the only difference being that patients treated with mechanical thrombectomy were much more likely to have preoperative antiplatelet use. We then looked at perioperative characteristics and importantly noted that there's a significantly lower number of interventions used in patients treated with a mechanical thrombectomy. In addition, they were much more likely to be discharged with an antiplatelet. Regarding postoperative outcomes, we found that patients treated with mechanical thrombectomy had lower rates of primary patency. However, primary assisted patency and secondary patency were similar between groups. In addition, there was no difference in rates of post-thrombotic syndrome, and there was no differences in rates of moderate/severe post-thrombotic syndrome. We then conducted a sub-analysis looking exclusively at patients treated with mechanical thrombectomy versus catheter-directed thrombolysis alone. We first characterized post-thrombotic syndrome, and although there appeared to be a trend towards catheter-directed thrombolysis having higher rates of PTS, this was statistically insignificant. We then looked at moderate/severe post-thrombotic syndrome and noticed that catheter-directed thrombolysis resulted in significantly greater rates of severe post-thrombotic syndrome relative to mechanical thrombectomy. Again, we conducted logistic regression to identify risk factors for post-thrombotic syndrome. Importantly, mechanical thrombectomy was not a risk factor for the development of post-thrombotic syndrome. Female sex was protective against post-thrombotic syndrome. Infrainguinal DVT extension was a risk factor for PTS, and preoperative antiplatelet use was protective against post-thrombotic syndrome. We conducted linear regression to look at Volta score. Importantly, mechanical thrombectomy, once again, not associated with increased Volta score. Female sex was associated with a decreased Volta score. Body mass index greater than 30 was associated with an increased Volta score, and prior history of DVT was associated with an increased Volta score. So we found that mechanical thrombectomy was not an independent predictor for the development of post-thrombotic syndrome or independently associated with increased Volta score. However, patients treated with mechanical thrombectomy experienced lower rates of 1-year primary patency. It's important to note, however, that primary assisted and secondary patency rates were not different between groups. Some of the limitations of our retrospective analysis are that we had a small sample size, we didn't include wound data, and we had a lack of patient-reported quality of life measurements. So we identified risk factors for the development of post-thrombotic syndrome with a focus on the use of mechanical thrombectomy. Infrainguinal DVT extension, male sex, and the lack of preoperative antiplatelet use were significant predictors of PTS. Prior DVT, male sex, and BMI greater than 30 were all independently associated with greater Volta scores. So the use of large bore mechanical thrombectomy in the treatment of iliofemoral DVT is not a significant predictor for the development of post-thrombotic syndrome. It appears safe and as effective as lytic-based therapies for the reduction of PTS and iliofemoral DVT. And based on the lower rates of moderate/severe PTS relative to CDT alone, there may indeed be benefit to rapid mechanical thrombus removal. Further research into the durability of mechanical thrombectomy and patient-reported outcome measures is required. Thank you, and I can take any questions.
Did any of these patients get stented? Did all these patients get stented?
A large portion. It was about 90% of the patients got stented.
What was your post-operative anticoagulation for the patients?
It was a mix. So because the timeline ranged so widely, there's a huge heterogeneity in the amount of like antiplatelet and anticoagulation use. But generally, it was similar. Like it was consistent with the era in which the operation was done.
And are you approaching all these from the knee, or like how are you starting the treatment? Are they coming like prone, coming up from the popliteal, or is it iliac?
I don't have that off the top of my head.
Was there any crossover between the groups? You put a lytic catheter in somebody, drip them for 24 hours, and then nothing happens, so you switch to clot?
The patients treated with mechanical thrombectomy did not receive any lysis.
Okay, so it was straight clot treatment.
Yeah.
Interesting.
Hey, Nitin Singh. Yeah, that was a really nice study. And one thing I think that's beneficial, it confirms that mechanical thrombectomy, single times, one-time use could potentially prevent these patients from having to stay in the hospital, stay in the ICU getting lytic therapy, coming back to the OR or angio suite to get repeat angio. So I think this is an important study, and the way you looked at it with the Volta scores is really nicely done. So just a comment to say it was a really nice study.
Thank you.
Thank you.